Let's jump right in.
Okay, first up, retinal vein occlusion.
All right, the mechanism here is primary thrombosis in central retinal vein occlusion, secondary thrombosis at arteriovenous crossings, sclerotic arterial compresses adjacent venule causing turbulent blood flow in branch retinal vein occlusion.
So basically a blood clot blocking a vein in the back of the eye.
Yep. And if it's the main central vein, it's usually the clot itself forming there. But for the smaller branch veins, it's often kind of interesting.
How so?
Well, often it's a nearby hardened artery, sclerosis from maybe hypertension pressing down on the little vein where they cross.
Like pinching it off?
Sort of. It causes the blood flow to get all turbulent, rough, not smooth, and that makes a clot more likely to form right there.
Makes sense. So things like high blood pressure are a big risk factor, especially in older folks.
Definitely. We had a listener share a story about their grandfather, called in a total panic.
Oh no, what happened?
Said his vision in one eye just went suddenly. Painless, though. But he described it like someone had thrown a bucket of red paint across his vision.
Wow, red paint. So hemorrhages.
Exactly. The fundoscopic exam showed that classic blood and thunder look, swollen optic disc, lots of hemorrhages, puffy veins, cotton wool spots. Classic presentation.
And the management. Give his history.
They focused right on the underlying hypertension, of course, and then discussed maybe anticoagulants or anti-VEGF injections for the swelling and other complications. Sudden, painless, unilateral vision loss with that exam finding. That's the key.
Got it. Okay, moving on. Number 2, retinal detachment.
Right. Mechanism. Separation of neurosensory retina from underlying retinal pigment epithelium, leading to loss of choroidal blood supply, hypoxia, and degeneration of photoreceptors due to retinal tears, rhegmatogenous or attractional exudative, fluid accumulation, non-rhegmatogenous.
So the light-sensitive layer, the retina, actually peels away from the back of the eye.
Precisely. It loses its blood supply from the layer underneath, the choroid. No oxygen means the photoreceptors start to degenerate.
And this can happen from a tear or other ways.
Yeah, tears are the most common cause that's rhegmatogenous. Often happens when the vitreous gel inside the eye pulls away, but sometimes it's tractional, like scar tissue pulling, or exudative, where fluid builds up underneath.
We had a listener share a story about this too. Happened suddenly while she was just making dinner.
Really? What did she notice?
First, she saw a sudden shower of little black specks, like pepper, she said, and flashes of light, like lightning bolts off to the side.
Floaters and photopsia, classic warning signs.
Right. She didn't think much of it at first, but then it progressed. By the next morning, it felt like a dark, heavy curtain pulled down over part of her vision. No pain, just vision loss.
That curtain description is textbook. Does she have risk factors?
Yes, high myopia, which is a known risk. The eye doctor did an ultrasound and a dilated exam, saw the detached retina just floating there, looked gray and elevated.
Surgical emergency then?
Absolutely. She needed surgery right away, things like vitrectomy or a scleral buckle to reattach it and hopefully save her sight.
Crucial to act fast on those symptoms.
Definitely. Okay, next. Retinitis pigmentosa.
The mechanism here is quite simply progressive degeneration of photoreceptors and retinal pigment epithelium.
So unlike detachment, this isn't sudden, it's inherited, right? And it's a slow breakdown of those light-sensing cells and their support layer.
Exactly. It's a group of genetic disorders leading to gradual worsening vision loss over many years.
We heard from a parent about their son, David. His first symptom was trouble seeing at night.
Nyctalopia, or night blindness. Very common, early sign.
Yeah, they said he also started having trouble with his peripheral vision, bumping into things, missing things off to the side. It eventually became like tunnel vision.
That progressive loss of peripheral vision is characteristic.
During his eye exam, they found a classic triad. Optic disc pallor. The nerve looked pale, thinning retinal blood vessels, and these distinctive bone spicule pigment deposits in the retina.
Ah, yes. Those bone spicules are a hallmark finding on fundoscopy. Any associated conditions?
They checked for a beta-lipoproteinemia, which can be linked. Unfortunately, the sources don't mention a cure. Management is really about support, low vision aids, genetic counseling for the family.
A tough diagnosis definitely requires long-term adaptation.
Indeed. All right, number 4, papilledema.
Okay, mechanism. Increased intracranial pressure, rejumble secondary to mass effect, causing impaired axoplasmic flow in optic nerve, leading to optic disc swelling, usually bilateral.
So this is pressure inside the skull getting too high.
Right, and that pressure gets transmitted along the optic nerve sheath, squeezing the nerve where it enters the eye.
And that squeezing Messes up the nerve's internal transport system.
Exactly, the axoplasmic flow. It's like a traffic jam inside the nerve fibers, causing the optic disc, the nerve head you see in the eye, to swell up. Usually happens in both eyes.
We had a message from someone describing some pretty classic symptoms.
Like what?
Really bad headaches, worse in the morning or when bending over or coughing Valsalva maneuvers. Also, their vision would sometimes just gray out for a second, and double vision sometimes.
Transient visual obscurations, diplopia, headache worse with Valsalva, textbook signs of increased ICP.
They also mentioned a weird whooshing sound in their ears, timed with their heartbeat.
Pulsatile tinnitus, another key symptom, and on exam.
The fundoscopy showed exactly what you expect. Bilateral optic disc swelling, blurred margins, the optic cup was kind of obliterated, dilated, twisty veins, enlarged blind spot too.
That's papilledema. So the next step is neuroimaging, MRI usually, to find out why the pressure is high. Could be a tumor, could be idiopathic intracranial hypertension.
Right. An important point, if you see papilledema in someone with really high blood pressure,
that signifies malignant hypertension, a medical emergency. Management hinges on finding and treating that underlying cause of the high pressure.
Got it. Okay, number 5. Relative afferent pupillary defect.
Mechanism. Unilateral or asymmetric lesions of afferent limb of pupillary reflex, due retina optic nerve.
Also called a Marcus gun pupil. So this tells us something's wrong with the signal coming from one eye, right? Yeah. The afferent pathway.
Exactly. The pathway carrying the light signal to the brain is damaged on one side or damaged more severely on one side than the other.
So the brain basically thinks less light is coming from that eye, even if the light source is the same.
Precisely. And that affects how the pupils react when you test them.
How do you test for that?
It's the swinging flashlight test. We had a listener describe having blurry vision and pain when moving one eye.
Sounds like maybe optic neuritis.
Could be. So during the exam, the doctor performs the swinging flashlight test. They shine the light in the good eye, both pupils constrict, normal. Then they quickly swing the light to the affected eye.
And instead of constricting more or staying constricted,
both pupils actually dilate a bit or constrict much less strongly. That paradoxical dilation when light hits the affected eye is the relative afferent pupillary defect.
So it confirms the problem is in the afferent pathway, the optic nerve usually on that side.
Correct. It's a key sign in things like optic neuritis, which is often linked to MS, as you said, but also other optic nerve issues like ischemia, trauma, giant cell arteritis, even a central retinal artery occlusion. Finding the RAPD points you towards investigating those causes.
Makes sense. Okay, number 6, Horner syndrome.
The mechanism here involves sympathetic denervation of face causing, patus, slight drooping of eyelid, superior tarsal muscle, anhidrosis, absence of sweating, and flushing of affected side of face, meiosis, pupil constriction.
So damage to the sympathetic nerves controlling one side of the face.
Exactly. These nerves handle things like slightly lifting the upper eyelid via the superior tarsal muscle, pupil dilation, and sweating. Damage that pathway, and you lose those functions on that side.
Leading to that classic triad. Droopy lid, small pupil, no sweating.
That's the one. Pitosis and hydrosis, though the anhidrosis, the lack of sweating, can sometimes be absent or only affect a small area, depending on where the nerve lesion is.
We heard from someone who noticed it after a walk. Looked in the mirror.
And saw.
Right eyelid was a bit droopy, right pupil was smaller than the left. And later, they realized after exercising, the left side of their forehead was sweaty, but the right side was totally dry. Maybe some flushing too. And a dull neck ache.
A perfect description. The ptosis, anhidrosis, meiosis, the PAM mnemonic helps remember it. That neck ache is also important.
Why the neck ache?
Well, locating where the sympathetic pathway is damaged is crucial. It can be a first-order neuron problem originating in the brainstem, like a pontine hemorrhage, or a second-order neuron issue, maybe a Pancoast tumor in the lung apex pressing on the chain, or a third-order neuron problem, often involving the carotid artery, like a dissection. That often presents with pain, like the neck ache this listener had.
So finding Horner's prompts a search for these potentially serious underlying causes.
Absolutely. In his case, it led to diagnosing a carotid dissection, which needed urgent treatment.
Critical connection. Okay, moving on. Number 7, cavernous sinus syndrome.
Mechanism. Secondary to pituitary tumor mass effect, carotid cavernous fistula or cavernous sinus thrombosis related to infection spreads due to lack of valves in dural venous sinuses.
Cavernous sinus, that's that space near the pituitary gland, packed with nerves and blood vessels, right?
Exactly. It's a critical junction box. It contains cranial nerves, 3rd, 5, V1, V2, and 6, plus the internal carotid artery and sympathetic fibers.
So something goes wrong in that sinus.
It can affect multiple structures at once. Causes include pressure from a nearby pituitary tumor, an abnormal connection between the carotid artery and the sinus veins, a fistula, or a blood clot, often from an infection spreading from the face or sinuses because those veins lack valves.
Sounds like it could cause a really confusing mix of symptoms.
It absolutely can. We had a listener describe a really bewildering experience. Started with one eye not moving properly, seeing double.
Okay, ophthalmoplegia. Which nerves?
Variable, but often 3, 4, and 6 are involved, controlling eye movements. Then the skin around that eye felt numb, and then their cheek went numb too.
Involving V1 and V2, the sensory branches of the trigeminal nerve.
Precisely. And they also noticed their eyelid on that side was slightly droopy, and the pupil was smaller.
So Horner syndrome features as well, from the sympathetic fibers running through.
You're correct. You can even get proptosis, the eye bulging forward. It's this combination of multiple cranial nerve palsies, especially affecting eye movement and facial sensation, V1, V2, often with Horner's, that points strongly to the cavernous sinus.
And diagnosis.
Clinical presentation raises suspicion, then imaging, usually MRI, is needed to pinpoint the cause, the tumor, the fistula, the thrombosis. Treatment depends entirely on that underlying cause.
Complex area, complex syndrome. All right, number 8, delirium.
The mechanism is key here. Usually secondary to illnesses, for example, CNS disease, infection, trauma, substance use, metabolite-electrolyte imbalance, hemorrhage, urinary fecal retention, or medications, example, anticholinergics.
So delirium isn't really a disease itself, it's more like a symptom, a sign that something else is wrong physically.
That's the crucial point. It's an acute disturbance in attention, awareness, and thinking. It comes on suddenly, often fluctuates over the course of the day, and it's almost always triggered by an underlying medical issue or medication.
Very different from dementia, which is gradual and progressive.
Exactly. Acute onset, fluctuating course, inattention, those are the hallmarks of delirium. Dementia is typically chronic, progressive, and consciousness isn't usually clouded in the same way.
We had a classic story from a listener about their grandmother, usually very sharp, but overnight became completely disoriented.
How did it manifest?
She was agitated, calling out for relatives who had passed away, couldn't focus on conversations, seemed only vaguely aware of where she was. Just a dramatic change from her baseline.
And the cause?
The nurses quickly suspected something, checked her urine, found a raging UTI, a bladder infection.
Very common trigger, especially in the elderly. Infections, metabolic issues like electrolyte problems, dehydration, new medications, constipation, even just being in an unfamiliar hospital environment can precipitate delirium.
So the management is?
Find and treat the underlying cause. In this case, antibiotics for the UTI. Plus, supportive care, reorientation, ensuring hydration and nutrition. It's rarely a primary psychiatric issue. Always look for the medical trigger.
Super important distinction.
Okay.
Number 9, schizophrenia.
Mechanism involves altered dopaminergic activity, increased serotonergic activity, decreased dendritic branching.
This is a primary psychiatric disorder, unlike delirium. Chronic, severe, affecting thoughts, perceptions, emotions.
Right. It involves complex changes in brain chemistry. Dopamine and serotonin pathways are heavily implicated, and also structural changes like reduced connections between brain cells, the dendritic branching.
It often presents with those positive and negative symptoms, right?
Correct. Positive symptoms are things that are added to experienced delusions, hallucinations, disorganized speech or behavior. Negative symptoms are things that are lost, flattened emotions, reduced speech, lack of motivation.
We heard from a parent about their son, Michael, who developed symptoms in college.
How did it start?
He became convinced the TV was sending him secret messages, that strangers were watching him.
Delusions. Paranoid delusions.
Yes. And he started hearing voices commenting on everything he did.
Auditory hallucinations, also very common. Any disorganized behavior. He became very withdrawn, socially isolated, rarely left his room. His speech became harder to follow sometimes. And the negative symptoms were there too. His emotions seemed really flat, like he was wearing a mask. He lost interest in classes, just had no motivation.
Flattened affect, alogia, avolition, textbook negative symptoms, and cognitive deficits are usually present too.
How is it diagnosed? It needs to be present for a while.
Yes, the diagnostic criteria require symptoms for at least 6 months, with at least 1 month of active phase symptoms like the delusions or hallucinations.
Right.
If it's shorter, it might be schizophreniform disorder.
And treatment.
Antipsychotic medications are the cornerstone, particularly the second-generation ones. But psychosocial interventions, therapy, support groups, occasional rehab are absolutely crucial for long-term functioning. A complex condition requiring comprehensive care.
Definitely. All right, halfway there. Number 10. Distal renal tubular acidosis, type 1.
Okay, kidney time. Mechanism. Inability of alpha-intercalated cells to secrete hydrogen ions, leading to no new bicarbonate generated, resulting in metabolic acidosis. So this is a problem in the distal part of the kidney tubule. Those specific cells, the alpha-intercalated ones, just can't pump acid hydrogen ions out into the urine properly.
Exactly. And if you can't secrete acid, you can't regenerate bicarbonate, which the body needs to buffer acid. So acid builds up in the blood, metabolic acidosis.
And this type is linked to kidney stones, right?
Strongly associated with nephrolithiasis, yeah. Because the urine stays alkaline, calcium phosphate stones tend to form.
We had a listener who felt constantly drained and kept getting painful kidney stones.
Makes sense. What did the labs show?
Consistently acidic blood, a metabolic acidosis, but with a normal anion gap. And crucially, even though their blood was acidic, their urine pH was always high, usually above 5.5.
That's the key diagnostic feature, the inability to acidify the urine despite systemic acidosis. Normal anion gap metabolic acidosis plus inappropriately high urine pH plus kidney stones points right to type 1 RTA. Hypokalemia, low potassium can also be present.
And management.
Treatment involves giving alkali, like sodium bicarbonate or potassium citrate, to correct the acidosis and raise urine citrate levels, which helps prevent stone formation. Got it. Keep the urine pH paradox in mind.
Okay, next. Proximal renal tubular acidosis, type 2.
Mechanism. Defective proximal convoluted tubule bicarbonate reabsorption, leading to increased excretion of bicarbonate in urine, resulting in metabolic acidosis.
So this time the problem is proximal, earlier in the tube.
Yo.
And it's not about secreting acid, it's about reclaiming bicarbonate.
Correct. Normally, the proximal tubule reabsorbs the vast majority of filtered bicarbonate. In type 2 RTA, that reabsorption is defective. So lots of bicarbonate gets lost in the urine, leading to metabolic acidosis.
Is this one linked to anything specific, like type 1 is to stones?
It's often associated with Fanconi syndrome.
Fanconi syndrome.
Yeah, that's a generalized defect in proximal tubule reabsorption. So besides losing bicarbonate, you also lose glucose, amino acids, phosphate, uric acid, all in the urine.
Ah, okay. And the phosphate loss can cause problems, especially in kids.
Exactly. Phosphate wasting leads to rickets or osteomalacia. We heard from parents whose daughter was diagnosed with rickets, and labs showed this acid-base issue.
So her presentation included the bone problems due to phosphate loss. What about the acidosis in urine pH?
She had a normal anion gap metabolic acidosis like type 1, but the urine pH is trickier. Initially, when bicarbonate is spilling, the urine pH might be high. But once the blood bicarbonate level drops low enough, the distal tubule, which is working fine, can still acidify the urine, so the pH might eventually drop below 5.5.
So the urine pH isn't as reliably high as in type 1. The key is the bicarbonate wasting and the Fanconi association.
Precisely. Normal anion gap metabolic acidosis, significant bicarbonate wasting, especially early on, often with other features of Fanconi syndrome, and rickets in children.
And treatment, since they're losing bicarb.
You need to give large doses of alkali, much larger than for type 1 because so much is just lost. Sometimes thiazide diuretics are used to help increase bicarbonate reabsorption indirectly. And addressing the underlying cause of Fanconi, if possible, makes sense. More bicarb needed.
Right, number 12, hyperkalemic tubular acidosis, type 4.
Mechanism. Hypoaldosteronism or aldosterone resistance leading to hyperkalemia, causing decreased ammonia synthesis in proximal convoluted tubule and decreased ammonium excretion.
Okay, this one involves potassium hyperkalemic and aldosterone.
Right. The root cause is either the body not making enough aldosterone or the kidneys not responding to it properly. Aldosterone normally helps the kidney excrete potassium and acid.
So low aldosterone effect means high potassium.
Yes, hyperkalemia. And the hyperkalemia itself then interferes with the kidney's ability to produce ammonia in the proximal tubule. Ammonia is crucial because it binds hydrogen ions to form ammonium, which is how the kidney normally excretes a lot of acid.
So no aldosterone effect, high potassium, less ammonia production, less acid excretion, metabolic acidosis.
You got it. That's the chain of events.
We had a listener feeling really weak and tired. Labs showed alarmingly high potassium and acidic blood.
Classic scenario. What else did they find?
Normal anion gap metabolic acidosis, along with the hyperkalemia. Those two together are the hallmark.
And common causes.
Often seen in people with diabetes, especially those with kidney involvement, causing hyperendonymic hypoaldosteronism. Also chronic kidney disease itself, or certain medications, like
Yeah.
ACE inhibitors, ARBs, potassium-sparing diuretics, and NSAIDs.
Exactly. Drugs that interfere with the renin-angiotensin-aldosterone system or directly affect potassium handling. The diagnosis rests on finding that normal anion gap metabolic acidosis with hyperkalemia and low urine ammonium excretion, often with evidence of low aldosterone or resistance.
Management. Focus on the potassium.
Yes, managing the hyperkalemia is key dietary potassium restriction, maybe loop diuretics or potassium binders, alkali therapy for the acidosis, and addressing the underlying cause if possible, like adjusting medications. Hyperkalemia is the big clue here.
Definitely. Okay, shifting gears a bit. Number 13, nephritic syndrome.
Mechanism. Glomerular inflammation leading to GBM damage, causing loss of RBCs into urine, dysmorphic RBCs, hematuria. This decreases GFR, resulting in oliguria, azotemia, increased renin release, and hypertension.
So nephritic means inflammation of the glomeruli, the kidney's filters.
Inflammation damages the glomerular basement membrane, the filter itself. This damage creates holes big enough for red blood cells to leak through into the urine.
Hence the hematuria, blood in the urine.
Yes, and importantly, the red blood cells often get damaged squeezing through, so they look misshapen, dysmorphic. Finding red blood cell casts in the urine clumps of RDCs formed in the tubules is highly specific for glomerular inflammation.
And the inflammation also affects filtering function.
It does. It reduces the glomerular filtration rate, GFR. Less filtering means less urine output, oliguria, buildup of waste products in the blood, azotemia, and the kidneys release more renin, leading to hypertension.
We got a story about an 8-year-old boy, Timmy, who got sick after having strep throat.
Ugh. Post-streptococcal glomerulonephritis is a classic cause of nephritic syndrome. What were his symptoms?
About 2 weeks after the sore throat, he got puffy face and feet swelled up. His mom noticed he wasn't peeing as much, and his urine looked dark, like cola or tea.
Edema, oliguria, hematuria, textbook. And his blood pressure
Was high. Labs confirmed the azotemia, and the urine showed hematuria with those specific red blood cell casts. Proteinuria is usually present, but typically not in the massive range.
So the clinical picture: hematuria with RBC casts, hypertension, oliguria, azotemia, often after an infection like strep points straight to nephritic syndrome. Other causes exist too, like IgA nephropathy or lupus nephritis.
Management.
Focuses on controlling blood pressure, managing fluid overload with salt restriction and diuretics, maybe RAAS blockers. Sometimes corticosteroids or other immunosuppressants are needed, depending on the specific cause. RBC casts are the key finding for glomerular inflammation.
Got it. Okay, contrast that with number 14, nephrotic syndrome.
Mechanism. Podocyte damage leading to impaired charge barrier, causing proteinuria. Hypoalbuminemia results in increased hepatic lipogenesis and hypercholesterolemia. Antithrombin loss causes hypercoagulability. IgG loss leads to infections.
So nephrotic is also a glomerular problem, but the main issue is damage to specific cells called podocytes.
Exactly. Podocytes are crucial for maintaining the filtration barrier, particularly the charge barrier that normally repels large proteins like albumin. Damage them, and that barrier fails.
Leading to massive protein loss in the urine.
Massive proteinuria, yes. That's the defining feature, typically defined as more than 3.5 grams per day. This huge loss of protein, especially albumin from the blood, causes hypoalbuminemia.
And low albumin in the blood leads to
Edema, lots of it, because albumin helps hold fluid in the blood vessels. Without it, fluid leaks out into the tissues, causing generalized swelling.
Makes sense. What about the other features?
The low albumin signals the liver to try and compensate by making more proteins, but it also ramps up production of lipids, leading to hyperlipidemia, high cholesterol. You also lose important proteins in the urine, like antithrombin III.
Which increases the risk of blood clots.
Correct. Hypercoagulability is a major risk, and you lose immunoglobulins, like IgG.
Making patients more prone to infections.
Yes. So, massive proteinuria, hypoalbuminemia, edema, hyperlipidemia, risk of thrombosis, risk of infection. That's the constellation of nephrotic syndrome.
We heard from a listener whose husband woke up one morning incredibly swollen.
How bad was the swelling?
His eyelids were like balloons, ankles, huge, severe pitting edema, both periorbital and peripheral. He also noticed his urine was really frothy.
Frothy urine is classic for heavy proteinuria.
Yeah, labs confirmed it. Massive protein loss, incredibly low albumin, sky-high cholesterol. He felt exhausted.
Yeah.
Urine microscopy might show fatty casts or oval fat bodies, too.
So the diagnosis is based on those characteristic lab findings. Common causes differ between kids and adults. Minimal change disease is common in kids. In adults, think FSGS, membranous nephropathy, diabetic nephropathy, amyloidosis.
Management sounds complex.
It involves managing the symptoms, diuretics for the edema, statins for hyperlipidemia, maybe anticoagulation, and crucially, treating the underlying glomerular disease, often with steroids or other immunosuppressants depending on the cause. The mnemonic FADED can help remember the features: proteinuria, hypoalbuminemia, edema, hyperlipidemia, thrombosis risk, infection risk.
Shaded. Good one. Okay, number 15, nephritic nephrotic syndrome.
Mechanism: severe GBM damage leading to loss of RBCs in urine plus impaired charge barrier, causing hematuria plus proteinuria.
So this sounds like the worst of both worlds. Severe enough damage to cause features of both nephritic and nephrotic syndromes.
Exactly. The damage to the glomerular basement membrane is so extensive that you get both the inflammatory features, allowing red blood cells through, like nephritic, and the severe disruption of the charge barrier, allowing massive protein loss, like nephrotic.
So patients present with
A combination: significant hematuria, often with RBC casts, plus hypertension and azotemia, the nephritic parts, but also massive proteinuria, 3.5 grade, hypoalbuminemia, severe edema, and hyperlipidemia, the nephrotic parts.
We got a story about a listener's brother with really alarming mixed symptoms.
Like what?
His urine was dark red, like blood, but also incredibly foamy. He was swollen all over face, legs, generalized edema. Blood pressure was through the roof.
So hematuria, massive proteinuria, implied by foaminess, edema, hypertension fits perfectly. Did they mention oliguria or azotemia?
Yes, those were present too, along with the implication of RBC casts, given the blood urine, the full picture.
It really signifies severe glomerular injury. Certain conditions like membranoproliferative glomerulonephritis, MPGN, or severe lupus nephritis often present this way.
Management must be challenging.
Very. It depends heavily on the underlying cause, but often requires aggressive treatment, frequently involving potent immunosuppression, alongside managing all the complications of both syndromes: the fluid overload, hypertension, clotting risk, infection risk.
A truly severe kidney injury pattern. Okay, number 16. Infection-related glomerulonephritis.
Mechanism: type 3 hypersensitivity reaction with consumptive hypocomplementemia.
We touched on this with the nephritic syndrome case, the post-strep example. This mechanism explains the why.
Right, it's an immune response gone awry after an infection, most classically group A strep, but other bacteria or viruses can trigger it too.
Type 3 hypersensitivity, that means immune complexes, right? Antigen-antibody clumps.
Exactly. These immune complexes form in the circulation and then get deposited in the glomeruli. That deposition triggers inflammation.
And the inflammation consumes complement proteins.
Yes, the inflammatory cascade activates the complement system, using up complement proteins like C3. So measuring low serum C3 levels is a key diagnostic clue.
We heard from a parent whose daughter developed symptoms about 2 weeks after having confirmed strep throat.
Perfect timing. What symptoms?
Puffy eyes, swollen ankles, peeing less, and her urine looked like root beer or smoky brown. Blood pressure was up too.
Periorbital edema, peripheral edema, oliguria, hematuria, hypertension. Classic nephritic picture developing 1-3 weeks post-infection.
So the diagnosis involves the clinical picture, the recent infection history, and those lab findings.
Yes, low C3 is very suggestive. You can also check for evidence of the recent strep infection, like elevated ASO or anti-DNase B titers. A kidney biopsy isn't always needed, but would show characteristic lumpy, bumpy, granular immune complex deposits on immunofluorescence, sometimes called a starry sky pattern on electron microscopy.
And management.
Primarily supportive. Manage the hypertension and fluid overload. The good news is, especially in children, it usually resolves on its own over weeks to months. Low C3 post-infection is the key association.
Got it. Number 17, Alport syndrome.
Mechanism: type 5 collagen mutation, X-linked dominant, leading to irregular thinning and thickening and splitting of glomerular basement membrane, resulting in nephritic syndrome.
So this is genetic, a problem with collagen.
Specifically type 5 collagen, which is a crucial building block for basement membranes, especially in the kidneys, glomeruli, the inner ear, cochlea, and the eyes.
And the mutation messes up that building block.
Yes. The most common form is X-linked dominant, caused by mutations in the COL4A5 gene. This leads to an abnormal glomerular basement membrane that's prone to splitting and damage over time.
Causing kidney problems, like nephritic syndrome.
Often presents with persistent hematuria starting in childhood, which can progress to proteinuria, hypertension, and eventually kidney failure.
And because type IV collagen is also in the ear and eye.
Patients typically develop sensorineural hearing loss, usually progressive, and various eye abnormalities like retinopathy or anterior lenticonus, a conical bulging of the lens.
That sounds like the classic triad: kidney disease, hearing loss, eye problems.
Exactly. The mnemonic, can't see, can't pee, can't hear a bee, sums it up nicely. Congenital cataracts can also occur.
We heard about a nephew who had persistent blood in his urine from a young age, started failing hearing tests.
Consistent with Alport? How is it confirmed?
Family history was suggestive, and a kidney biopsy showed the characteristic changes on electron microscopy, that basket weave appearance, due to the irregular thinning, thickening, and splitting of the GBM. Genetic testing can also confirm the specific mutation. And being X-linked, males are usually more severely affected than females.
Correct. Management is supportive, trying to slow kidney disease progression, often with ACE inhibitors, managing the hearing loss with aids, and monitoring for eye complications. Basket weave GBM on EM is a key finding.
Okay, shifting to the bladder now, number 18, stress incontinence.
Mechanism. Outlet incompetence, urethral hypermobility intrinsic sphincter deficiency, leading to lead on increased intra-abdominal pressure, for example, sneezing, lifting.
So this is linkage that happens with physical stress, coughing, sneezing, laughing, exercising.
Right. The problem lies in the outlet. Either the urethra moves too much because of weakened pelvic floor support, hypermobility, or the urethral sphincter muscle itself is weak, intrinsic sphincter deficiency.
So when pressure inside the abdomen suddenly increases.
The weakened outlet can't stay closed, and urine leaks out involuntarily.
We heard from a new mom experiencing this after childbirth.
Very common scenario. Pregnancy and vaginal delivery can weaken pelvic floor muscles. What did she describe?
Embarrassing leakage whenever she coughed, sneezed, laughed hard, or tried to exercise, like jumping on a trampoline. She started avoiding those activities.
Textbook stress incontinence. The key is leakage with those specific physical exertions that raise intra-abdominal pressure. Diagnosis is often clinical based on the history. A physical exam might show urethral hypermobility during coughing, a positive cough stress test.
Management starts conservatively.
Usually, yes. Pelvic floor muscle exercises, Kegel exercises are first line. Lifestyle changes like weight loss if appropriate. Pessaries can sometimes help support the urethra. If those aren't enough, surgical options like mid-urethral slings are very effective. Leakage with cough, sneeze, laugh, stress incontinence.
Got it. Number 19, urge incontinence.
Mechanism. Detrusor overactivity, leading to leak with urge to void.
Okay, so this isn't about physical stress. It's about the bladder muscle itself, the detrusor.
Exactly. The detrusor muscle contracts suddenly and involuntarily, even when the bladder isn't full. This causes a sudden, intense urge to urinate that's really hard to suppress.
Leading to leakage because of that overwhelming urge, sometimes called overactive bladder.
Right. Overactive bladder is the symptom complex of urgency, frequency, nocturia, with or without urge incontinence. The incontinence part is when leakage actually occurs due to that uncontrollable urge.
We had a listener describe it as incredibly frustrating and unpredictable.
How so?
They said it's like an alarm goes off in my bladder and I have to go right now. Sometimes they couldn't even make it across the room to the toilet before leaking. Lots of frequency and waking up at night too.
That sudden, compelling, difficult to defer urge is the key symptom. Diagnosis is mainly clinical based on these characteristic symptoms. Urodynamic studies can sometimes be used to formally demonstrate detrusor overactivity, but aren't always needed. Neurologic conditions like stroke or MS can be underlying causes.
Management differs from stress incontinence.
Yes. First line includes behavioral therapies like bladder training, scheduled voiding, learning urge suppression techniques. Pelvic floor exercises can help too. Medications are often used, typically anticholinergics like oxybutynin, or beta-3 adrenergic agonists like mirabegron, which help relax the detrusor muscle. Sudden urge leading to leakage, urge incontinence.
Right, last one. Number 20, overflow incontinence.
Mechanism. Incomplete emptying, detrusor underactivity or outlet obstruction, leading to leak with overfilling.
So this time the problem is the bladder doesn't empty properly.
Correct. Either the detrusor muscle is too weak to contract effectively, underactivity, or there's a blockage preventing urine from getting out easily, outlet obstruction.
And because the bladder doesn't empty, it gets overly full.
Right. It gets distended, the pressure builds up until it overcomes the outlet resistance, and then urine just sort of leaks or dribbles out because the bladder simply can't hold anymore. Often happens without a strong sensation of needing to void.
We heard from someone experiencing constant dribbling and always feeling like they hadn't fully emptied.
Typical symptoms. What else?
They described frequent leakage of small amounts of urine, day and night, needing to wear pads constantly. Sometimes straining to void, but still feeling like more was left behind.
That sensation of incomplete emptying is a big clue. Diagnosis involves checking the post-void residual, PVR, urine volume, how much urine is left in the bladder immediately after voiding. This is usually done with a bladder ultrasound or catheterization. A high PVR confirms incomplete emptying.
And what causes the incomplete emptying?
Two main categories. Bladder outlet obstruction, very common in men due to benign prostatic hyperplasia, BPH, but also urethral strictures or even severe pelvic organ prolapse in women or fecal impaction, or detrusor underactivity often due to nerve damage, like in diabetic neuropathy or spinal cord injury, or sometimes medications.
So in the listener's case,
Turned out he had an enlarged prostate, BPH, causing obstruction.
management must target the underlying cause then.
Absolutely. If it's obstruction, you treat that medications or surgery for BPH, for example. If it's detrusor underactivity, strategies might include timed voiding, double voiding, trying to urinate again shortly after finishing, or sometimes intermittent self-catheterization to ensure the bladder gets emptied regularly. Indwelling catheters might be needed in some cases. Constant dribbling, incomplete emptying, high PVR, overflow, incontinence.
Wow, what a journey through 20 incredibly diverse and impactful medical conditions. From the intricate workings of our eyes to the vital functions of our kidneys and even the complexities of the brain and bladder. We've really seen how understanding the why behind a symptom is so crucial.
Absolutely. Each story, I think, really highlighted how those mechanisms, the underlying why, translate directly into the symptoms people experience and how that guides the path to diagnosis and management.
It definitely underscores that behind every medical term, there's a human experience. Connecting those dots. That's really what being well-informed is all about.
Couldn't agree more.
We really hope this deep dive has given you, our listeners, a clearer picture, not just of these specific conditions, but maybe also of that fascinating interplay within the human body. It's quite a reminder that every detail matters.
It is. And maybe it raises a question for you to think about. What other medical topics, maybe ones that seem really complex on the surface, do you find yourself wanting to unravel? Bridging that gap between the dense scientific detail and how it actually plays out in the real world.
That's a great thought to leave everyone with. Thank you for joining us on The Deep Dive.
Always a pleasure.
Until next time, keep that curiosity alive and keep exploring.